to our group.
Yes. Jagat Janni.
We are live, sir.
दोनों में?
Yes, sir.
So, namaskar, greetings from Heart Care Foundation of India and Confederation of Medical Association of Asia and Oceania. Dr. K.K. Aggarwal here. Welcome, everybody. Our special guest, Dr. Jagat Kaul, Dr. Arun Aggarwal, Dr. Kalra, Upasna ji, Dr. Sanchita, Bijon ji, and Dr. Jaikishan Alpat here. Would request Dr. Arun Aggarwal to chair this meeting. And this meeting is important. The flow of the program will be Dr. Kalra will speak, then Professor Kaul will speak. It will be then open for discussion, and Dr. Arun Aggarwal will summarize and moderate the panel discussion. The subject is that we are all talking about immunity. Now, 4 cases have happened of reinfection. 1 in Hong Kong, 1 in Belgium, 1 in Netherlands, and 1 in USA. Confirmed cases of reinfection with slightly modified, mutated version of the virus. So the virus is only giving immunity against the same strain. With a mutated virus, it is not giving immunity. We were not bothered when the Hong Kong case came, because we said that the second case was mutated virus, but it did not produce symptoms. It produced early antibodies, and the patient was asymptomatic. But the case which came in USA 18th of April, and then he was negative on 28th of April with 3 negative tests, became positive on 31st May with a different strain, but needed hospitalization and oxygenation. Therefore, patients, you can't say that the virus is giving immunity and converting a virus into a low-grade virulent virus. That has been disapproved by this US case. So time has come for us to understand innate versus adaptive immunity. Innate immunity is like rafa-dafa. That means if you have a chore in your house, then you try to solve it at your level, or the police comes and police case ko rafa-dafa kar deti hai without filing an FIR. So in an innate immunity, no memory cell activation takes place and FIR is not lodged. If a FIR is lodged, then memory adaptive B lymphocytes or lymphocytes comes, memory lymphocytes or memory B cells and memory T cell comes. They file an FIR, a modus operandi is noticed. And even if you don't have a specific police, whenever a similar incident occurs anywhere in the body, that file will open, will direct what antibodies to produce. That's adaptive immunity. Now in children, because every virus is a novel virus, for a child, every virus is a new virus. So the word novel is for adults, not for a child. A newborn getting any infection is a novel virus. So any novel virus, a child will activate his system for both innate immunity and adaptive immunity. And a major role is played by the thymus, which produces macrophages, dendritic cells, through a hormone called thymosin alpha. And that also is responsible for memory T cell and B cell. So we presume that in the initial phase of life, enough T cells and B cells can come. But now we are getting novel viruses in adults. And these novel viruses in adults may not be producing enough both innate and adaptive immunity. So is there a role of synthetic thymosin alpha, where 3 trials are going on in India, 2 trials are going on internationally, 5 trials are going on, that should there be a role of a thymus extract Now, we have seen placental extract as a thrombogenic for a coagulation thing. We have been using it for years together. We have been using, so thymus extract cannot be used because thymus is not present in the adults. So you cannot, so therefore it has to be a recombinant or a synthetic thyroid extract or a thymus extract or a thymus hormone. So for that, we need to understand actually what thymus plays a role, what is the importance, and whether these T cells and B cell which is produced, do they last, have they any role? So we thought of discussing this in a series of discussions to understand the role of thymus. So I requested Dr. Kalra to talk to Professor Kaul. She is here. Maybe next time we have a physiologist also joining us, because from anatomy we may also need to know the role of a physiologist, the physiology of thymus. I particularly feel that the role of thymus is very, very important to understand COVID-19 situation. I hand it over to Dr. Kalra to introduce Professor Kaul and the subject, because Dr. Kalra is also, because you require anatomy and you require a child. So child doctor, we have Dr. Kalra and we have a professor of anatomy who can talk about it.
Thank you, Dr. Aggarwal. With the permission from the chair, firstly, may I opportunity to introduce our new member to this group, Dr. Kaul. She is a doctor, professor, and former head of anatomy, Maulana Azad Medical College, and consultant academics and advisor to Baba Ambedkar Sahib Medical College, Government of Delhi.
Thank you, sir.
Dr. Aggarwal has already introduced the topic, the role of thymus. In pediatric age group, thymus plays a very crucial role for development of T cells, and which they circulate and fulfill the requirement throughout the life. If initially and even at birth, thymus is very much enlarged and increased in size by 1 year, and then till puberty is very active and produce the hormone thymosin, and which is very, very crucial, vital for development our immune system. So after the age of say 40, 50, it starts regression. And even at 70 years, is only fibrous, some tissue is left, and it is only weigh 5 grams by the age of 70 years. In the recent study, which I think I have already shared with you all, in a scientific study, it was seen that COVID-19 infected patients with severe involvement of a lung, they have a thymic hyperplasia. And it is a good indicator, prognostic value. If thymic hyperplasia is seen in a critical patient of COVID-19, mortality was significantly low compared to other group which has not shown the thymus hyperplasia. With these words, now I will request Dr. Kaul to teach us about normal anatomy and functioning of,
Thank you.
yeah.
Thank you very much. We'll learn together. Teaching is a very far thing. I'll share my slides with you. You have disabled screen sharing.
Ritu is
Yes,
doing.
sir. Please, sir.
Ritu, please.
Yes, sir.
Can you disable?
Please, sir, please.
Yeah, you can share now.
Okay, sir. I begin by thanking all of you and Dr. Aggarwal for inviting me and giving me an opportunity to myself understand thymus in a different light. Although I have a PhD under me on thymus and the thymic development and histogenesis, but I had not looked at thymus with this kind of an approach. So thank you for giving me an opportunity to try to learn a bit more about thymus. And the topic that you had given me, assigned to me, was the role of Role of thymus in enhancing immunity against COVID-19. So let's try to understand what thymus is about. It's a primary lymphoid organ besides bone marrow, and it provides the whole body and the microenvironment in which the cell precursors, which are coming from bone marrow, originally in embryonic life from yolk sac, they undergo development, differentiation, and clonal expression, which is extremely important for us to later survive all kinds of infections and pathogens. And it provides specificity of T cell responses and provides immune tolerance to self, which we know when it goes wrong, what all can happen. This is achieved by interactions between thymocytes, epithelial sites, antigenic presenting cells, and chemical factors of the thymic environment. And the beauty is that the thymus is part of the neuroendocrine axis of the body. It influences and is influenced by products of this axis. So it varies at different stages of life under the influence of different physiological and pathological states. I am not going to teach you too much anatomy, but what am I going to do is I'm going to do the functional, more of the functional aspect of the thymus. We all know that a greater part of this lies in this region in the superior, anterior, and inferior mediastinum, and reaches up to the border of fourth costal cartilage. Spirally extensions can be in the neck also, and we all know that happens because it comes from the thymic pouches. It comes from the pharyngeal pouches, sorry. And shape is, it takes the shape of whatever is around it. It's molded to the adjacent structures. To begin with, it's reddish in color. I used to do fetal autopsies in MAMC, and it was sometimes very, very difficult to pick up thymus in a 20-week fetus and distinguish it from lungs and heart, because it would be so intimately associated with them. And covered by a distinct capsule till you reached a fetus of about 7 to 8 months, that we could see a beautiful capsule over thymus and delineating it from the lungs and the heart. The older thymuses are yellowish in color. We all know why, because it gets adipose infiltration, and only thing that surrounds it from the mediastinal fat later is that thin capsule. That's why we need to mention it. If we look at this slide, then when we take the microstructure of thymus, then we can see distinctly, even under light microscope, the magnification power 100, we can see that there are two distinct zones. A zone which is denser outside, covered by a very well-defined capsule sending septa in. This part can further be divided, which we call cortex, into a part which is just below the capsule, known as the subcapsular part, extremely important for the functioning to happen properly, and medulla, which has epithelial cells as well as lymphocytes, but cortex is predominantly having thymocytes. The capsule sends septa into cortex, but the septa go only up to the corticomedullary junction, and they divide the cortex into smaller lobules. Beneath the main cortex, the lobulation forms, these septa form the pathway for the blood vessels and nerves to travel. Let's look at the structure. The components of the microstructure are epithelial cells and thymocytes. Besides that, there are other cells which we'll talk subsequently. If we look at the epithelial cells, then one second, I seem to have lost my slide. If we look at the epithelial cells are present over here in this region. We go further. These green cells that you can see, these are the epithelial cells, and you can say they are interspersed throughout the cortex and throughout the medulla. Now let's see how many stratas of these epithelial cells and how many types of these epithelial cells are, and what do they do. Type 1 cell is just subcapsular. And this is a cell that by its action, it attracts by its charge, surface charge, the blast cells which are coming from the bone marrow. So extremely important, because if this didn't work properly, the blast cells will not be attracted towards the thymus, right, from the fetal stage, and these are negatively charged cells. Type 2 are large active cells. You can see these type 2 cells here, and this is type 3 cell. As an anatomist and a microstructure expert, I can pick them up. I can make out the difference, but we don't need to discuss that over here. They are also cortical in presence, and you can see this is a large cell. These are the thymic nerve cells. They are subset of type 2 and type 3 and specialized epitheliocytes. And they are, by virtue of their size, obviously you can understand, they will be associated with lot more thymocytes than the others. So you can see the huge cluster of thymocytes surrounding this nursing cell. And it does prime these thymocytes. When we talk of the function of the epithelial cells, it primes these thymocytes to further differentiate. Type 5 and type 6 medullary cells are present in the medulla, and type 6 are the commonest. And you can also see that we have these epithelioid congregations which have an eosinophilic. In this picture, we cannot see it very well. Eosinophilic center portion with little amyloid kind of a deposit. And these are the Hassal's corpuscles. Originally thought to be age-related or graveyard of the cells, but they definitely have, we have seen in our work that they also start in fetal life. By 5th month of intrauterine life, Hassal's corpuscles are very well established. And as age goes on, they increase. Why they increase? What is their actual function? It's still not very clear. If we look at the lymphatic population, then we have as we said just now, blast cells in the subcapsular region. This picture shows it very well. They don't expect any markers. There's no marker on it. These cells undergo mitosis, and you can see after mitosis, they develop T cell receptor sites, and then they become a CD3 cell. The cluster determinant of these cells is CD3, with further expression of the proteins. They become double positive for CD4 as well as CD8. These are called double positives. And from here, and the CD4 and CD8, you can see here, sorry. You can see the CD4 and CD8 cells, they are here. This is corticomedullary, almost lower part, inner part of the cortex, corticomedullary junction. This is the area of CD3 cells, and this is the area of CD4 cells. And here, a phenomenal amount of apoptosis takes place, and only those cells who are very, very, let's say, abundant in the markers are allowed to survive. And these are allowed to get into the medulla. And this medulla then has either CD4 cells carrying CD4 charge or CD8 cell, and they become single positive. They are either CD4 or CD8. And another type of cell which has got large lymphocytic, large granular lymphocytes, which act by phagocytosis, by some kind of lysosomal activity, are the natural killer cells which are also present in the cortex. If we look at the T lymphocyte, then What kind of immunity does it carry? Does it produce antibodies? No, it has an effector action and a controlling action. Now, what is the effector action? Effector action is it can directly kill by producing cytotoxic substances with release of toxic lysosomal proteins. So what it does, there's a blister, it attaches to the other cell, to that tissue cell that has a pathogen or a virus, and causes blisters on the surface and kills the cell by that. Or it recognizes MH class protein. Now, this is something that happens, this is a lot of biochemistry involved in it, that cells identify self-protein. These cells identify self-protein at the stage of apostosis, and only those cells which identify the self-protein are allowed to go into the medulla. And that MHC class 1 protein is characteristic of that particular individual. So they recognize those cells, don't do anything to those cells, but any other cell which has something attached to this MHC class 1 protein, those are the cells they will attack. As I said before, the natural killer cells are devoid of any T cell receptors, and they are not restricted by MHC protein. So they are actually killer by nature. They are like assassins. And there's a lovely description in one of the articles that Dr. Kalra said, they called them ninja cells of the lymphocytes. Now, what are the indirectly, what do they do indirectly? Indirectly, they produce cytotoxins. And we have heard so much in these 6 months about interleukins, and we have all kinds of interleukins, which I'll talk in a minute. Then they can act, this was a direct action. They can also act by controlling. Now, what is this controlling action? The controlling action is they will either induce or suppress the immune responses in B and T lymphocytes, which are, or any other variety of cells which are derived from bone marrow. That means indirectly, it can also prime the B lymphocyte. It's priming the T lymphocyte. It will also prime the non-lymphocytic population, which we'll do in a minute. And then it can also cause delayed hypersensitivity related to T cells by releasing cytokines, which act upon whatever it has to act upon by phagocytosis and chemotaxis. Now, that's all aggression. Is there anything that is going to suppress it also? So we have suppression cells also. They are certain T cells. When stimulated, they suppress the activity of B cells and also of T cells. So this is a beautiful balance between positive aggression and negative suppression. And this fine balance is what we are losing out in COVID. We are losing this fine balance, and what was happening that the interleukins, the cytotoxins, all kinds of controls are acting in a hyperdrive, and which is also, it's like, as Dr. Aggarwal would say, tell us at MAMC, that when you are very aggressive, not only the site that needs aggression, but the surrounding also gets hurt, and that's exactly what is happening. If we look at the thymic hormones, then we have Thymulin, and I needed to add this, relies on zinc for its biological activity, because we are hearing so much about people telling us on WhatsApp, have zinc, you must have zinc every day, you must have zinc every day. So yeah, it has some relevance. Thymosin, thymopentine, thymic humoral factors, they exert immunomodulatory responses and control over the lymphocyte maturation. They induce markers of early differentiation of the lymphoid cells and enhance T cells. Other soluble factors, as we have already talked, are the cytokine complexes, and interleukin 1, 2, 4, 6 are secreted by thymocytes, and interleukin 1, 3, 4, 6, 7 are by thymic epithelium. Cells bearing receptors for these cytokines are all present in the thymus. We have non-lymphocytic thymic cells also. Cells of mononuclear phagocytic system, they have monocytes. Plenty of monocytes Thymus has. Very easy to identify even under light microscopy. We don't have to go to EM microscopy to identify them. And there are interdigitating cells which form a beautiful network. They present antigen to T cells as they mature from cortex to medulla because they have to get antigenic stimulus to be able to recognize that antigen. So as the cell is going from cortex to medulla, they present those antigens to T cells so that they start recognizing them. Besides that, we have fibroblasts and myeloid cells. The role of myeloid cells is not really, well known. It's only seen very well in rodents that the myeloid cells cause contraction of the lymphatic capillary and push the lymph forwards. The neuroendocrine thymic interaction, extremely important. Hormones can influence thymic function, and the thymic factors can often affect other endocrine organs. It's amazing. Epithelial cells have receptors for sex steroids, triiodothyronine, and luteinizing release hormone sites. Receptors on thymocytes for corticosteroids, oxytocin, and estrogen. This I have still not been able to figure out why there should be for oxytocin and estrogen. I could think of corticosteroid receptors, but I am not able to understand why oxytocin. I shall, for myself, do more research on this and try to find out. High levels of corticosteroids kill cortical thymocytes. Probably this was the reason when they were giving higher doses of corticosteroid, they were not responding to it. In fact, they were becoming worse. And low levels have a potentially thymopoietic effect. That means if we give steroid in low doses, it can be beneficial to the proliferation of lymphocytes. Also, they enhance the migration of prothrombocytes into the thymus. So that's important, that it'll help catch the blast cells. Thymic changes are very important because, as Dr. Kalra has also said, as we grow in age, from 20 grams, it becomes almost 5 grams. And the weight is replaced by fatty tissue. Very little thymic tissue is left. But in spite of our saying that it has totally kind of atrophied, there is always number of thymocytes present, though greatly reduced, but thymocyte production and differentiation persists throughout life. That does not ever stop, though starts becoming lesser after 4th decade, becomes very much less after 6th decade. That's why probably the deaths in 7th decade, 8th decade are a lot more than otherwise. Dr. Kalra has already told us that the weight is about 20 grams and comes on to about 5 grams eventually. Now, our question today is, does thymus play a role in severity of COVID-19? What is the status of thymus when a person has had infection? Unfortunately, in India, we're not doing postmortems. Otherwise, I would have loved to do a project in which I would have looked at thymus and seen what is the condition of the thymus. But observations of past few months have shown that older adults were at an increased risk of grave illness compared to children. Now we know children are, Dr. K.K. Aggarwal has also told us that children are exposed to so many infections, so many vaccinations, immunizations. We don't know what all is actually protecting the children. We have heard of BCG giving some kind of cross immunity to COVID-19. We have heard of whether the influenza vaccine is going to help us protect ourselves against COVID-19. So there are lots and lots of factors we can attribute to children being at a lower risk. But emerging research has shown that there is a marked decrease in the number of T cells in gravely ill patients. Now, I think I would later like to even ask a question of you, sir, whether this is, observed in all severe patients or only those severe patients where there is no thymic hyperplasia. Factors that cause loss of function is multifactorial. There are, as we know, aging is by itself a factor that is going to cause loss of function, or the pathogens may be more infective and prevalent in elderly, but they may also affect the young ones, like influenza. It's prevalent in elderly as well as children, but it's more infective or more severe in elderly. And these are the gerophilic nature type of infections, as against infections including COVID-19, which are gerolavic, that is substantially more severe in elderly patients compared to the young adults, compared to children. But one question came to my mind myself. I was thinking that it's not that the young adults are not getting affected. It's not that some of the young adults are not getting severe illness. In those, should we go back and retrospect, look at their T cell population? I do not know whether we can get that research, but I shall try at least at BSA and MAMC to get some kind of data from them.
Thank you, Dr. Paul.
No, I still have a few.
Okay, please.
Now, age-related senescence we have talked about already. My observation that TNB lymphocytes have over the time opened up vistas of knowledge, but thrown open many questions. Like today, it has thrown open a big question to us in this new infection. It has promoted the understanding of memory cells, tolerance, autoimmunity, autodeficiency, as well as inflammatory and immunopathological phenomena. And as you rightly had sent us the article, science says, if we have the role of immunity boosters will be if we can convert a 70-year-old immune system into to behave like a 40-year-old immune system, we may win this fight after all. And that's what Dr. K.K. Aggarwal said, the clinical trials on the thymic hormones. Maybe at some point of time, we may not be then so worried about these infections. And he had also sent us a reference, and I had gone through that the recent investigations have highlighted role of increased pro-inflammatory cytokines, impaired type 1 interferon responses, and the functional exhaustion of antiviral lymphocytes in COVID patients. I acknowledge the following, and I thank you for giving me 10 minutes. Thank you very much.
Thank you, Dr. Kaul. I think in last 20-25 minutes, you have taken us through a journey which reminded us our earlier days, which reminded us the whole course of medicine and the entire journey of the clinical side without realizing, and all colleagues will agree that it seems that the entire process of COVID-19, where we are listening, is it regarding the T cells or lymphocytes or CD4, IL6, all the parameters being talked about during COVID-19 are directly, indirectly related to this smallest possible part of the body weighing 20 grams during childhood. And when it comes to the age for which we are worried, the age of 60s and 70s is hardly weighs 5 grams. So that means we should never underestimate something which is small and cannot be effective. It looks like whatever wonderfully you have described, not only the anatomical but the entire physiological process of thymus during the whole life cycle and how effective it is. And I fully agree that all the parameters, whatever is being considered as regard the immune factor is concerned, there seems to be very important linkages, and these linkages are important for us to understand more and more in relation to COVID-19, and perhaps we may find some good solution. To continue with the dialogue, now the question arises when we find that the thymus is a very important factor as regard COVID-19 is concerned. I will like to again go back to Dr. K.K. Aggarwal. K.K., what you feel that you said so many trials are going on, and as per your clinical experience, would like to comment upon.
So I will go back to the Google and the PubMed. And if I go back to the clinicaltrials.gov, it is mentioning about large number of trials happening on thymosin alpha 1, which is called TA1, which is a 28 amino acid synthetic peptide, identical to natural thymosin alpha 1 produced by the thymus gland. So most of the trials which are going on, including India, I spoke to a couple of people in Mumbai and Pune who are heading this trial, and they all are saying is that matter is worth exploring, and something or the other we are talking when we are talking about IL6 inhibitors, when we are talking about everything about T cell and B cells, why not look into that? That's one. Number two is, if we see this disease, it has a low lymphocytes. This disease has low lymphocytes as a diagnosis. And we know absolute lymphocyte is less than 1,000, patient is serious, less than 800, very serious. And specifically, if we do, there is a reduction in CD4 count. And that's the reason we said this virus behaves like a HIV virus, because we have heard of CD4 count only in HIV becoming low. So therefore, this virus somehow or other, I would say this is a T cell disorder. This virus causes T cell disorder. Therefore, we wanted to understand more about the T4, because this is causing CD4 cell. It is a T cell dysfunction. T cell produces interleukin 6. Interleukin 6 orders the liver to produce a C-reactive protein that causes then tissue necrosis factor, and now we know that IL6 estrogen is an inhibitor. Now, madam has shown us the way how it acts, because women are getting less. Pregnancy is asymptomatic. We are seeing menstruation, the symptoms disappear. So somewhere or the other, estrogen and phytoestrogen is soya. So somewhere or the other, estrogen is an inhibitor of IL6. Maybe the connection which madam was saying is not there, because we know that people who eat estrogen reduces interleukin 6. Origin of interleukin 6 comes from the T cell. So that can explain the link there. And haldi, which is curcumin, reduces tissue necrosis factor. Therefore, every patient I am asking them कि रोज सुबेरे सोया पनीर का टिक्का हल्दी लगा के गरम करके खाओ, भून के खाओ. That gives you both TNF blocker and ILF interleukin 6 inhibitor. So somehow or other, I think we need to understand more. We have got a beautiful analysis by Madam Kaul, but we would like to ask her if we can devote a little bit 5 more minutes, make it more basic. What is the role of CD4? What is the role of CD8? What is the role of thymocyte? We want to go a little bit more in basics to understand that. Specifically, what is the role of an interleukin? Why there are so many interleukins 1 to 6? Why it is needed? Why? What is basically, so little bit more simplify, because Imagine us to
Paul?
be a first class of a MBBS student sitting here.
Yeah, that's why I said in the beginning that Dr. Kaul has taken us right from the journey of our undergraduation to the
I
entire
want her
course
to be
of.
the first class of MBBS.
That's right. Dr. Kaul, will
Sir,
you take over?
Hanji, you can hear me?
Yes, yes.
Although I'm not an expert on interleukins because I'm not a biochemist by profession, but these are glycoproteins, different glycoproteins, which have different pathways of action. I'm sorry, I'll not be able to throw light on them because biochemistry.
What about the difference between CD4 and CD8 cells?
What is the, sorry, sir, can you come again?
CD4 cell, importance of CD4 cell and thymus. CD4, which is reduces in HIV, is shown to be reduced in COVID-19. Is it related to thymus? Is it related to, so if I give a thymosin hormone, will it increase CD4 cell?
Yes, it will increase CD4 cells, sir. It will increase CD4 cells.
And will it also reduce IL6 as an inflammatory marker?
I am not sure of that. I'm not sure of that.
So
I
do
think
you think there is a justification of exploring of a possibility of thymosin alpha because it's not going to harm. That means giving as we give thyroxine hormone, I'm equating it to testosterone. When you have you have a menopause, you have an andropause. In andropause, there's always been a debate to give a little bit of testosterone as a replacement. Similarly, if you are an adult and elderly, when you are talking about elderly immunization, and if you give an immunization without a thymosin, you are incomplete. So if you are giving elderly immunization, then you give.
But I think we may have to do look up a lot of literature to see how the interactions would happen.
Dr. K.K. Aggarwal, I think after listening to both of you, I will definitely like to explore another aspect which Dr. Kalra did mention, that what is the status, anatomical status of this thymus gland in elderly people.
So
Theoretically, we know.
Yeah.
Theoretically, we know that it gets shrinked, it gets replaced by adipose tissue, and perhaps exploration, surgical exploration.
Sir, we have done some work on thymus and we have explored, explored this aspect.
Yes.
Anjali, can you open
it? But at the same time, I'm looking for radiological evidence now. That I want to know. Unfortunately, मेरे कोई radiologist इसमें नहीं है. If there is any or anybody would like to comment, in a normal city of this area, can we locate thymus gland?
Yes, I think I have shared, or I will share an article in which they have studied the thymus gland in patients of COVID-19. But there is some gray adjustment is required for in the CT scan procedure to identify thymus. Is it possible? Yeah.
Anjali, can you share, Anjali Misra?
Always explore the possibility.
Yourself and share something on IL6.
But Dr. Aggarwal, we need to know more about CD4 and CD8 cells because both of them, are expressing
Sunila will like to pitch in.
Yeah, that's what I'm talking. I'm still stuck at CD4 versus CD8 cells. So one of them, like we say that CD4 is helper cells and the other one is known as cytotoxic cells. And then, CD4 glycoproteins are serving as at the T cell receptor. Whereas CD8, basically glycoprotein, they are serving again as the T cell receptor. So that's where we need to exactly first make out the difference between CD4 and CD8. Because CD4 is also recognizing the antigens on the surface of the antigen presenting cells. Whereas, CD8 is recognizing antigen on the surface of all the nucleated cells. So somewhere I think we need to look at between the two, and then, how, we go ahead with this. It is important to know the basics first, as Dr. Aggarwal was pointing out. So I'm just stuck at that point, So
Okay, that means once we have raised this topic, very relevant topic, I must say thanks to Dr. K.K. Kalra and Dr. K.K. Aggarwal of bringing this topic for discussion, and perhaps this discussion may lead to something more and more amongst all of us and our relevant people. But I think
there's a cell death actually.
Dr. K.K., once we talk about immunoboosting, that this topic of immunoboosting has been talked about in relation to COVID-19 in such a big distance, and they are immunoboosters which are of various kind, that the immunoboosters are there, which are which has been introduced in the market at a very high cost versus our natural immunoboosters. I would like to throw some light on that.
I said natural immunoboosters. I already said TNF blocker is curcumin and phytoestrogen is soya. So I've already said these are available. And all Ayurvedic preparation, basically, whether you talk about Giloy, whether you talk about Ashwagandha, they all are immuno boosters. But basically, no scientific study is available as a trial as on today. But yes, every diet, if you take 7 colors and 6 tastes, they build up your immunity. But we are specifically talking about, is there any booster which boosts the thymus gland? That probably we don't have any evidence to talk about it. So what I am talking about is, if a patient develops an infection, can we prevent the second infection? Number one. Number two, suppose let me say, if I give a thymosin alpha with a BCG vaccination, will it produce a better coverage of an innate immunity than a BCG vaccination alone? Or do we have any other, apart from synthetic hormones of a thymosin, do we have any herb which can increase thymosin levels? No data is available. No data is available. I mean, I'm exploring a lateral thinking. This group is here every week. We pick up a lateral thinking, something which is nobody is thinking. Because I was interviewing one of the professor at AIMS, and he was quoting Professor Vinod Kumar. He says, treat the patient, evidence will follow. Look, don't look at the evidence. And I liked it. He says in a COVID-19, don't look at, there is no evidence. Evidence has to be produced. So if like-minded people not look at it, evidence will never be produced. If we are looking at America to do and find out and tell us that thymus extract will work, it will be too late. So I am only trying to say is, let's think of more and more about T cell, B cell business, and see whether we can actually, it was actually an opportunity for complete Ayurvedic system in India to explore and come out with at a very molecular level and find out which herbs improves what. But unfortunately, they are still busy in only prevention. They are only talking about prevention. They are not talking about the therapeutics with that.
But Dr. Aggarwal, whatever trials, for BCG also we are doing in healthcare workers in Germany, France, or Italy, and we are looking at the, the severity of symptoms. And then again, there are a lot of considerations, because you see, we are also looking at the countries which are having BCG as part of universal immunization program. There they have observed that, the morbidity and mortality both are less, but it could be also, till it is proven. If we do a trial, it has got a lot of implications, that I am withdrawing BCG from my program for the trial purposes, whether it is worth it or it is cost effective, and at what cost.
At the cost of... There are two things. When this is a novel illness, there are two things. When it is a novel illness, say for example, I myself have a responsibility to save myself. Okay, if I find that, say for example, today's Times of India says, how many? They says that if that report is correct, which I'm a little bit skeptical, 87,000 healthcare workers have developed the disease. 573 deaths amongst healthcare workers. 87,000 healthcare workers is more than number of cases China had in the whole population. We are talking about healthcare workers. So if I want to protect my healthcare workers, I still don't know my healthcare workers, do they have a high viral overload? No government is telling me. No government is doing a project on why healthcare workers are developing it. People used to say that there is no self-negligence in healthcare workers. There is no delayed diagnosis in healthcare workers. People, we are saying every day, लोग लेट आएंगे तो मरेंगे. But healthcare workers में ऐसा क्यों हो रहा है? Healthcare workers में ऐसा क्यों हो रहा है? In that situation, and these healthcare workers, statistics does not include people like Sanjay in IMA who died, who is not a healthcare worker but working with the healthcare with that. So
Yes,
the
sir.
number may be over a lakh. Number may be over a lakh. So can we do
Yeah.
something? How
Okay.
to?
I think
Definitely, very important
Dr.
point.
Sunila, there is a question from Dr. Bejoy Mishra. Professor
Thank you.
Bejoy Mishra,
Thank you.
will you
Thank you.
please?
Thank you very much. Thank you
Yes.
very much.
Thank
I think I am the only non-physician in the group.
But
I must come in, and firstly, I want to congratulate Dr. Jagat Kaul for the excellent presentation. I represent patient groups, you see, and I am part of this group because I learn a lot from you all. Today, what I learned and what I'm taking back, somewhere I heard you saying, you are not being made accessible to postmortem. That was a very, very you said, if I was being made accessible to postmortem, then I would have been able to figure out a lot of new understandings, discoveries, and maybe solutions to patients. And that has actually touched me, you know, in the sense that how do we resolve this? And we need to resolve this, because if we have to grow in science and all what we are doing every day on a Saturday morning at 11 o'clock, if we want to get it to its logical end, people like you should guide us in terms of how do we bring in policies which will allow people like you all who are scientists, who are experts, to access that knowledge which you are not able to access. That's my
Bijan ji, इसका आंसर बड़ा सिंपल है. Phase 1. Phase 1 is immediately after that a whole body CT scan as a virtual autopsy. And if we find some changes, then we can come back with a proper plan of doing a complete autopsy. हर आदमी की जिसकी डेथ हो रही है 2.5 मिनट के अंदर में whole body CT scan be done, and that can play the role of a virtual autopsy.
My only response to that is Dr. Aggarwal, and I would like to also hear from Dr. Kaul. In terms of, in a country like India, how can we and in what manner we can make it possible? Because as you know, we have several challenges in terms of the infrastructure, in terms of accessibility to CT scan or to get a scan done. So how do we go? So we have to find out a statistical model and ensure that how we can do it in a very statistical, significant manner, where experts like you all can access a data which tomorrow can be very credible and can move us forward.
I think, can I pitch in?
Well, Dr. Kaul, I'm waiting for Dr. Kaul to respond. I'm waiting for Dr. Kaul to respond.
Dr. Kaul?
Because she's coming for the first time.
Because, yes.
I personally feel it's very important for us to get this information.
Dr. Kaul, please.
I'm speaking, sir. I personally feel it's very important for us to get this information, because it was only after the information came from Italy did we realize that what it is doing to other structures besides lungs. That's when the whole information came to us. We did not know what all it did to the hemovascular system till then. Here, we are not touching the bodies, because I have been contacting, I think some of you will know Dr. Vijay Dankar. I have been asking him again and again that, are you guys doing autopsies? Can you give us some data, what's happening to the internal organs? But no, I have no idea whether MAMC is doing it or not. But Dr. KK Aggarwal's point is very valid. If instead of that autopsy, we can have a virtual autopsy. Now, one center can be made. One machine can be dedicated. You don't have to do every death that happens. We only have to do patients or deceased people who have in various age groups. That model can be created. And if we can do 200 CT scans also, we should be able to have credible data. This is what we have been telling everywhere, that we need to understand what's happening to body. Only then we will be able to work out something better. So you as sir, as policy planners, have to think of it.
Yeah, the work starts now, right away. The work starts.
Let me think upon raising funds for buying one CT scan only for a COVID research as a post-mortem virtual cases. Let me see. Let me negotiate with the company and see if we can buy. I can raise funds and buy one machine and give it to a hospital or a center who can do only do the virtual postmortem. Every death goes through there for 5 minutes like a ritual.
Yeah, good idea. So let's do this as a project, and I would definitely request and appeal to Dr. Kaul to be part of this initiative which Dr. Aggarwal just now announced. So it will be very nice of you to join in.
I think the world has to be grateful to Italy for giving us all that information that they did. And I'm sure it wouldn't have been easy for them to do the postmortems either.
So if it is...
You're absolutely right. Italy also has good things to offer to the world.
I agree, sir.
Any more comments?
If not,
Dr. Roy?
Kindly sum up, because the time is also up. Kindly sum up.
Thank you.
Okay.
Sir, only last comment I will raise, that there was a meeting, day before yesterday, because we have lot of unclaimed bodies as well. And, students are facing lot of shortage with regard to, Dr. Paul will give a comment on that. And then that was, with regard to that, whether, how we can persuade the government and make a channel that wherever there are unclaimed bodies and all, they can be utilized for teaching the medical students across the country. Because you see, we do not have a formal guideline. So I think one needs to look into in this direction also, because the committee members were at loss exactly how to proceed ahead with that. So I think that was another issue which I wanted to raise. So that will go a long way, because we are just
Thank you.
Having.
Thank you, Sunila. I think today's discussion was definitely a different type of discussion on this platform. We have been discussing it for last months, and we have discussed very important topic. But today's discussion had been extraordinarily satisfying to me, and I'm sure to all of you. Number one, the thought of discussing thymus, thanks to Dr. KK and Dr. KK Kalra, the way the knowledge has been given to us by Dr. J.M. Kaul, thank you very much for giving us the entire recollection of the thymus. And of course, many of the things were new to us also. But at the same time, ultimately, it has been correlated that it looks the thymus and COVID-19 has a lot to do together. It has definite relationship with some of us have realized globally, and that's why there is some research activities have started. Can we give it a big boost to it? Can we try to, as a structure, I'd like autopsy. I mean, this is one of the, but in relation to thymus, we must try to create more structured project, discuss with ICMR, discuss with teaching institution, and they can always try to bring more and more research project. And of course, as suggested by Dr. KK Aggarwal, virtual biopsy, autopsy, and Sunila is very fond of verbal autopsy, right? So if I combine virtual and verbal, I think that will make the best combination. And with this, I will like to say thanks to all of you for being with us. And let's continue with such type of useful discussion. And thank you, Dr. Kaul, again for joining us, and hope you will keep on joining. You will continue joining. Dr.
Anytime.
Bijon Mishra, wonderful comment from your side. You always
thank you.
give constructive ideas.
Thank you, Dr. Aggarwal.
Thank you.
very
Thank
much.
you very much.
And on behalf of Heart Care Foundation, thanks to all of you. Bye for now.
Bye.
Bye.